Hi, my name is Dennis Phillips, and I'm going to go over the respiratory system for the board review course. I have nothing to disclose. We'll first define the types of lung volumes, how we quantify them, the normal values, and the concept of time constants. Now, shown here is a graphical representation of the total capacity of our lungs and the components that make up that capacity. The rate at which these volumes, though, are achieved is not accounted for with static lung volumes. We will cover methods used to measure both the static and dynamic volumes, as well as other topics that are listed here: spirometry, dead space, nitrogen washout, exercise testing, and others. Total lung capacity is a static lung volume that quantifies just what its name implies, which is the total capacity of the lungs. Total lung capacity is additive of all the static lung volumes, such as inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume, and normal total lung capacity at about 5.8 liters. Now, residual volume is really the only volume that's not easily measured and not measured with spirometry. So if a volume includes residual volume as a portion of its volume, then we cannot accurately measure with using spirometry. The vital capacity is the volume expired with a slow, complete expiration after maximal inspiration without a forceful effort. The inspiratory reserve volume is that volume which can be obtained during inspiration above a normal tidal volume. The inspiratory reserve volume normally is about 3 liters, and we'll talk about time constant later. On the other end of a normal tidal volume breath is expiratory reserve volume. This is what you can exceed after a normal expiration, and it's about 1 liter in addition to the normal expiration volume. So what's left over is the residual volume, around 1.2 liters normally. There are fancy and expensive ways to measure the volume that are either difficult or, as I said, expensive. Helium dilution, which is measuring the volume and concentration of helium delivered, and then really just back calculating residual volume when the concentration equalizes. Nitrogen washout is very similar, and plethysmograph is expensive but involves a similar concept. Not commonly utilized for us clinically. And when it comes to tidal volumes, it's important to realize that normal tidal volume is only based on height and gender rather than actual weight. In fact, obesity causes lower tidal volumes for obvious reasons. So don't administer tidal volumes based upon actual weight. In general, normal is around 500, but clinically we apply lower tidal volumes routinely in critical care and for patients at high risk of perioperative pulmonary complications. The functional residual capacity is what allows us to intubate while maintaining oxygenation in an apneic patient. Think of it as your holding tank that is used up during apnea. Make sure you fill it with oxygen and get rid of the nitrogen. Adding the residual volume and expiratory reserve volume gives the FRC. Normal values are 2.3 liters. As an example, if 200 milliliters of oxygen, 250 milliliters of oxygen are used per minute, this will give you about 9 minutes of oxygenation during apnea. Of course, this is in a healthy, non-obese patient. It is also important to quantify the rate at which volumes come in and out of the lungs. That rate which these volumes fill and empty the lungs reflects compliance and resistance of the lung as well as the chest wall. After a maximal inspiration and a maximally forced effort to expel air from our lungs, this is called the forced vital capacity. In men's, this measures 4.8 liters, and in women, 3.7 liters. Normally, about 80% is expired in the first second. This is the FEV1. Now remember that any time in medicine we discuss a percent, consider what is the total. This holds true for pulse oximetry as well. Percentage of what total volume matters, so they will take the ratio of the FEV1 to the FVC and also measure it. And this is most helpful to differentiate obstructive versus restrictive lung diseases. And again, it's normal to exhale 80% of your forced vital capacity in the first 1 second. Forced expiratory flow quantifies the rate of air exiting the lungs during the middle portion of a forced expiration by definition. Now, although it's easier to think about these volumes and rates as occurring equally throughout the lung fields, it's really not true. Depending upon patient positioning, disease states, acute and chronic, or both, different areas of the lungs may inflate and deflate at different times. Lung inflation can be described mathematically by the time constant T. That time equals the total compliance times the airway resistance. And again, regional variations in resistance or compliance not only interfere with alveolar filling, but can cause asynchrony in alveolar filling during inspiration, where some alveoli units may continue to fill as others are emptying at the same time. Variations in their time constant within a normal lung can be demonstrated in normal individuals breathing spontaneously during abnormally high respiratory rates. Rapid shallow breathing reverses the normal distribution of ventilation, preferentially favoring upper or non-dependent areas of the lung over the lower areas. Now, there's a normal amount of dead space that occurs in all of us, anatomical dead space such as the trachea and main bronchi, and alveolar dead space that occurs with either pulmonary embolus or obstructive lung diseases. This is essentially ventilation without perfusion. Now, as I said before, to accurately measure functional residual capacity, one needs to measure the residual volume as well. Nitrogen washout is a method where a specified concentration of nitrogen is delivered to a volume as the exhaled concentration declines, and you really just solve for the second volume, which is the FRC. Now, regarding oxygen uptake, the Bohr effect is a commonly tested property reflecting oxygen-hemoglobin dissociation curve. It occurs at the pulmonary capillary level where carbon dioxide elimination creates a more alkaline environment, favoring oxygen binding to hemoglobin from the alveolus. Now, energy production of any sort also has byproducts. Our mitochondria use aerobic metabolism of carbs, fats, proteins to yield two acetyl-CoA molecules, which eventually enters the citric acid cycle, producing a few energy byproducts and products, NAD, FAD, GTP, with carbon dioxide, as we all know, as the byproduct. Now, some pulmonary diseases require a trigger, and there are tests that apply this trigger to confirm the diagnosis. This is analogous to cardiac stress testing with rest and stressed images. So exercise-induced asthma is bronchospasm caused usually by dry airways. Therefore, after resting, spirometry measurements are obtained. Exercise spirometry is measured with nasal clamps. For the test to be accurate, one must reach the 40 to 60% of the maximum volume ventilation during exercise. And so if there's a 10 to 15% reduction in the FEV1, a positive test for exercise-induced bronchospasm results. Now we will discuss static and dynamic compliance rather than static and dynamic volumes. We'll go over this slide a bit later. We use flow volume loops as a graphical representation of pulmonary mechanics. Here's an example showing a positive response to bronchodilator therapy. The scooped out green expiratory slope flattens out after bronchodilator therapy, reflecting an improved expiratory flow rate. This is a good bronchodilator response. Now, this slide here is a favorite topic for testing, which shows the relationship of flow and volumes and how they change in different pathological states. In general, a fixed lesion will have a reduced flow rate with inspiration and expiration. Now, to figure out the variable lesions, just think about what is the intrathoracic pressure during inspiration. The intrathoracic pressure is more negative, and also what is the intrathoracic pressure during expiration, or it's more positive or less negative. So therefore, if the lesion is outside of the thorax, it will get sucked in by the negative force and become a more obstructive during inspiration, as you could see on the graph. And if the lesion is intrathoracic, it will become less obstructive during inspiration and more obstructive to flow during expiration. Some alveoli fill faster than others. Time-dependent elastic properties of alveoli is known as hysteresis. There are several causes. Laplace's law highlights the wall tension and radius's effect on alveolar expansion as one example. Distribution of volumes, pressures, regions of atelectasis, pneumonia, pulmonary lung volume, etc. can all affect the time-dependent elasticity or hysteresis of the lung. The pressure derived from the equation is that within the alveolus. The alveolar collapse is therefore directly proportional to the surface tension. Fortunately, in contrast to a bubble, pulmonary surfactant will decrease alveolar surface tension. Moreover, the ability of surfactant to lower surface tension is directly proportional to its concentration within the alveolus, resulting in a lower intraalveolar pressure in small alveoli. So as alveoli become smaller, the surfactant within them becomes more concentrated, and the surface tension is more effectively reduced. Conversely, when the alveoli are overdistended, surfactant becomes more dilute, and surface tension increases. The net effect really is to stabilize alveoli. Small alveoli are prevented from getting smaller, and large alveoli are prevented from getting larger. The elastic resistance is a function of the lung itself. Resistance reflects the friction of moving gas molecules along the walls of the airway, and the equations are represented there on the slide. Resistance to flow is affected most by the radius of the airway, and you can see in the equation for resistance, this is raised to the fourth power. Therefore, reducing your radius by half will increase by 16-fold the resistance. Resistance is reduced with larger lung volumes because the airway diameters are larger. Turbulent flow occurs in asthma exacerbations because the bronchospasm reduces mainly the airway diameter. Higher resistance increases exhalation time, and this leads to air trapping and increased FRC. Exhalation becomes an active process, and paralysis with non-depolarizing muscle relaxants prevents active exhalation by patients, and therefore gas trapping is more likely to occur. It increases intrathoracic pressure, reduces cardiac preload, increases right ventricular afterload, both of which eventually reduce left ventricular filling and cardiac output. The work of breathing, though, is a function of the change in pressure required to overcome elastic and resistive forces, the transpulmonary pressure, multiplied by the change in volume, or the tidal volume. Adding the inverse of the lung and chest wall compliance gives the total compliance, and this equation highlights how obesity can contribute to poor total compliance. Even if the lungs have a normal compliance, the change in volume divided by the change in transpulmonary pressure is the compliance. This slide is comparing the upright and supine positions on compliance. You can see that the graph on the right, that the lung and the chest wall become less compliant when a patient is supine, mainly due to the weight of the chest in this position. We'll talk about this slide in a bit. Lung compliance is a measure of how a change in the volume occurs for a certain transpulmonary pressure. The slide is a little incorrect here. The transpulmonary pressure equals the airway pressure minus the pleural pressure. Now, making the pleural pressure more negative will increase the transpulmonary pressure. Think of the airway pressure within the alveolus, and on the other side, the pleural pressure sort of opposing or helping, really, the airway pressure. Normal is about 0.2 to 0.3 liters for every centimeter of water pressure. Now, there is something called the pleural pressure gradient, and since the pleural pressure is more negative up high in the non-dependent areas of the lung, the alveolar volume is allowed to be greater because the atmospheric pressure doesn't have to push against a positive force. It's actually being sucked in by the negative pleural pressure. And therefore, the alveolar volume will be greater and more compliant in that reason. Again, the pleural pressure gradient, which is important to understand, is in the vertical dimension. Since pleural pressure is more negative in the superior regions and the airway pressure is atmospheric pressure, the alveoli are more easily able to stay open. They hold a larger volume compared to the dependent regions of the lung. Atmospheric pressure in those areas exceeds pleural pressure, and therefore the alveoli stay open. Now we'll discuss lung mechanics. This is just a graphical representation of lung compliance in obstructive, normal and restrictive lung disease, and it really just shows how the compliance curve flattens out with restrictive disease. For a small change in volume in restrictive disease, there is a large change in pressure. Ventilation perfusion, VQ, otherwise known as VQ matching, mismatching. Now, the inspiratory flow rates will influence to what degree the dependent and non-dependent regions of the lungs are ventilated, and I think this is often not thought about. This graph represents the change. A lower inspiratory flow rate, most air distributes to the lower lung fields, and higher rates, airflow, such as during exercise, the distribution becomes a little more even and approaches 1, allowing for more efficient VQ mismatching between the matching between the upper and lower lung fields. The distribution of perfusion is affected by gravity. Therefore, the position of the patient does become relevant. The concept of pulmonary vascular resistance and this graph is very similar to the classically taught west zones of the lung. It is in zone 4 in this example where patients develop rales first because the left atrial pressure exceeds alveolar pressure. The pulmonary vasculature protects against shunting with hypoxic pulmonary vasoconstriction. The constriction of vasculature in the hypoxemic region shunts blood to oxygenated areas of the lung, improving VQ matching. Other organs such as brain, muscle, etc. vasodilate in the setting of hypoxemia. Unfortunately, however, general anesthesia obliterates this protective effect. The diffusion of oxygen across the alveoli into the blood is dependent on the surface area, the thickness of the alveoli, and capillary membranes and the pressure gradients. Therefore, during apnea, diffusion of oxygen is still occurring. If a patient is not given supplemental oxygen following, say, a nitrous oxide anesthetic, then the diffusion hypoxia can occur. An example is when room air is inhaled and nitrous oxide diffuses back into the alveoli, further reducing oxygen tension, leading to hypoxia. Now, there are many influences on how much oxygen and carbon dioxide is dissolved into a solution like our blood, as well as how oxygen binds to and releases from hemoglobin, and is ultimately utilized in the citric acid cycle. The most important to understand and study is the oxygen-hemoglobin dissociation curve. But there are other effects. The same principles apply to the pressure of carbon dioxide on our blood, and we'll talk more about this. Hemoglobin's affinity for oxygen is less when the curve is shifted to the right. So, the more acidotic a patient is, the less binding of oxygen that occurs for a given oxygen tension. 2,3-DPG is created by erythrocytes during glycolysis, and it blocks, if you will, oxygen from binding to deoxygenated hemoglobin. So higher levels will reduce hemoglobin's affinity for oxygen. The effects of carbon dioxide tension on the body systems is also important to understand, especially its effect on the cerebral vasculature. In the central nervous system, this graph shows how cerebral blood flow changes with changes in mean arterial pressure, PaCO2, the PaO2. Cerebral blood flow, as you can see, is pretty constant under the variations of mean arterial pressure from about 50 to 150 millimeters of mercury. And the oxygen tension, cerebral blood flow is kept normal until about PaO2 of 60 or so and below, when cerebral blood flow then dramatically increases. Cerebral blood flow, however, is not held constant with changes in serum carbon dioxide levels. There is essentially a direct relationship for most of the curve, as you can see. Carbon dioxide levels have effects on the other organs as well. Hypercarbia will stimulate the respiratory center. It will do so maximally at about 100 millimeters of mercury, but then above that, hypercarbia will depress respiratory drive. It will increase pulmonary vascular resistance. It will augment hypoxic pulmonary vasoconstriction. Hypocarbia will block HPV. It will cause bronchoconstriction, and it will reduce lung compliance. On the cardiovascular system, hypercarbia increases sympathetic nervous system outflow, blood pressure, but blood pressure and cardiac output initially will increase. Once the CO2 rises above 80 to 90 millimeters of mercury, it leads to a reduced blood pressure, cardiac output, heart rate, and cardiovascular collapse and arrhythmias. But with hypocarbia, it leads to, pretty early on, a reduced cardiac output, CNS vasoconstriction. It depresses the sympathetic nervous system activity, leads to less myocardial inotropy, and decreases ionized calcium, which also reduces inotropy of the heart. And yes, it also has an effect on the gastrointestinal system. Hypercarbia leads essentially to increased hepatic pulmonary vein flow and splanchnic blood flow, and hypocarbia has the opposite effect. The kidneys are the compensatory organ for the lungs, and so, as you can imagine, hypercarbia causes the kidneys to retain bicarb in order to buffer the acid of hypercarbia. And the opposite occurs with hypocarbia, where the kidneys will eventually, over the course of 48 hours or so, start to waste bicarbonate. The basic interpretation of ABG should be something you are familiar with by now, and starting with the pH, really to define acidosis or alkalosis. Then looking at the PaCO2, keeping in mind that for every 10 millimeters of mercury rise in the PaCO2, the pH should drop around 0.08. To make the math easier, 0.1 reduction in pH for every 10 rise in PaCO2 is easier to remember. It will help you not to miss mixed acid-base problems. Now, the control of ventilation is a large topic, so we won't go into detail here, but you should review where the respiratory centers are, the central and peripheral chemoreceptors and what they do, as well as the innervation of the muscles of respiration and their reflexes. Now, the lungs aren't only for gas exchange. They act as a very good filter, and they have metabolic as well as immune functions to them. The fine pulmonary capillary network filters particles, plasminogen activator, heparin, and breaks down fibrin products. It stops pulmonary emboli from becoming left-sided emboli and stroke. It is also a reservoir for blood with a significant capacitance. The pulmonary endothelium are also active. They metabolize norepinephrine, serotonin, bradykinin, prostaglandins, and leukotrienes. Angiotensin-converting enzyme is actually bound to the endothelium of the pulmonary system. So it's more for just oxygen and gas exchange. Now we'll switch gears to discuss smoking and the anatomy of the lungs. Patients should know that they will benefit from smoking cessation perioperatively. You will see this all the time when smokers are having anesthesia. They will have more airway secretions. They'll have irritability of the airway leading to bronchospasm and wheezing and hypoxemia. And they'll also have a higher rate of other pulmonary complications such as pneumonia and reintubation. Now, lower pulmonary complication rates from cardiac surgery can occur if smoking cessation is at least 8 weeks prior to the surgery. For lung surgery, 4 weeks prior to lung surgery, smoking needs to be stopped in order to get a benefit. The goal is to reduce their carbon monoxide levels. Even small amounts of carbon monoxide will shift to the left, your oxygen-hemoglobin dissociation curve, and displace oxygen from hemoglobin. Smoking cessation reduces sputum production, improves mucociliary transport, so it is certainly worth it. Now let's review the respiratory anatomy of the nose, the pharynx, and the larynx. The larynx connects the inferior pharynx with the trachea. It has 3 functions. It maintains airway patency, it protects from aspiration, and it allows for vocalization. It is 5 centimeters in length. Its greatest resistance to airflow to the lungs is the larynx. The laryngeal musculature include the depressors and the elevators. The depressors are the omohyoid, the sternohyoid, and the sternothyroid muscle. The elevators are the stylohyoid, the digastrix, myohyoid, geniohyoid, and stylopharyngeus muscles. The internal branch of the superior laryngeal nerve provides sensation from above the vocal cords to the posterior tongue. Its external branch provides motor innervation to the cricothyroid muscle, responsible for laryngospasm. The recurrent laryngeal nerve applies motor to all other laryngeal muscles and sensation below the vocal cords. The superior laryngeal artery branches from the common carotid artery to supply the larynx with its blood supply. There's also cartilaginous anatomy. There are paired cartilages, the arytenoids, the corniculate, the cuneiform, and the unpaired cartilages, the thyroid, cricoid, and the epiglottic cartilages. Now regarding the vocal cords, the adult vocal cords are located approximately C4, C5 level, while infants are superior about 1 to 2 levels. With vocal cord paralysis, the affected cord assumes a median position even during inspiration. That's how you can define which cord is paralyzed. The main muscles of respiration are the diaphragm, the internal and external intercostals, the abdominal rectus, scalenes, and parasternal intercartilaginous and scalenus muscles provide accessory support of respiration during pathological conditions or during strenuous exercise. Now, some of the pharmacology of the respiratory system we can go into. The bronchodilators and anti-inflammatories are common drugs used to treat pulmonary disease. Beta-2 agonists, anticholinergic steroids, specifically glucocorticoids, leukotriene modifiers, mast cell stabilizers, IgE blockers. Albuterol has its onset in a few minutes. That's why it is a good rescue drug, the drug of choice. Tachycardia limits its short interval repeat usage. Intravenous epinephrine is beta-1, 2, alpha, and is not the first line for bronchospasm, but it will work at doses of 0.25 to 1 mics per minute IV. Certainly not the first line. Ipratropium is the typical anticholinergic used for acute treatment and has a longer half-life, 4 to 6 hours, than does albuterol. Tachycardia is also its limiting effect. As its name implies, it is derived from atropine-like substance. The beta-2 agonists are structurally similar to epinephrine. The chemical structure of beta agonists is shown here. Now it's really just comparing the beta-2 specific and non-specific. Compare epinephrine to albuterol and the two long-acting beta-2 agonists, how they are structurally different. And basically they have more organic side chains, which makes them more lipophilic, and therefore are longer acting than albuterol. The likely mechanism for the beta agonists in the cell is an increase in cyclic AMP, allowing for smooth muscle relaxation. The two main anticholinergics are ipratropium, that is aerosolized, and tiotropium, which is a powdered form, essentially, of ipratropium. It antagonizes the effects of acetylcholine that's released from airway parasympathetic nerves on the M3 muscarinic receptors that are on airway smooth muscle. It's used prophylactically and in maintenance therapy. It has a slower onset, and it makes them not used for rescue therapy. There are, of course, though, less adverse cardiac events with tiotropium because it is a powdered form. Now, glucocorticoids work intracellularly, and so they take some time to be effective. They will change the gene transcription, leading to a reduced CDT helper cells, which leads to reduced levels of cytokines such as interleukin 4, 5, and 13 levels. So these things take a while to have their effect. They're certainly not for the acute rescue therapy. They are part of the therapy, but other things need to take its place initially. So steroids can be taken enterically, IV, or inhaled. Now when inhaled steroids are used, there's no hepatic first pass, and their clinical effect is comparable to oral steroids, but with less side effects, including less or little adrenal suppression, little reduction in bone density, or cataract formation. Inhaled steroids have been shown not only to reduce morbidity, but also asthma-related mortality. So there have been important advancement in pulmonary disease treatment of asthma. Now the methylxanthines have a narrow therapeutic index. Theophylline is not used much as it previously was due to its therapeutic index and safer options that are more effective with morbidity and mortality data. The phosphodiesterase inhibitors' mechanism of action is to selectively target type 4 phosphodiesterase receptors, thereby reducing the degradation of cyclic AMP in the immune cells. This leads to an anti-inflammatory effect. Here are some of the pharmacokinetics and dynamics of theophylline. You may see this on boards, but it's for historic purposes in terms of clinical effect. This drug was used for COPD. It's 40% bound to protein, has a half a liter per kilo volume of distribution. It's 90% available if taken orally. It peaks in 1 to 2 hours. 8.5 hours is its half-life. Serum levels less than 20 are therapeutic. Complications that occur, or toxicities, more accurately, from levels of 20 to 25, nausea, vomiting, diarrhea, insomnia, and headache. And greater than 30, you can get seizures, tachyarrhythmias, especially with volatile anesthetics added on top of that, CHF, tachypnea, and hematemesis. When phospholipids are broken down by phospholipase C and A2, arachidonic acid is made, and there starts the cascade. From there, depending on the biochemical milieu, arachidonic acid is broken down, eventually to prostaglandins and thromboxane and leukotrienes. As their name suggests, leukotrienes originate from leukocytes. They bind to cis-LT1 receptors that causes smooth muscle contraction, increased microvascular permeability, and airway mucus secretions. Therefore, when leukotrienes are used, they block these effects. Before much was known about leukotrienes, they were called SRS-A, which is slow-releasing substance of anaphylaxis. Leukotriene modifier drugs are aimed at blocking the end products of arachidonic acid cascade. Cis-LT1 blocker, known as Singulair, is used commonly. Leukotriene D4 and E4 receptor blocker, Acolyte, essentially has the same effect. Now, mast cell stabilizers block chloride channels that indirectly block calcium influx. This calcium influx is essential for histamine-filled vesicles to fuse to the cell membranes and eventually to degranulate. Chromalin sodium is the classic examples, but it's really been replaced by leukotriene blockers. Monoclonal antibodies have become very effective in the treatment of many immune-related pathologies, including asthma, and they work by binding circulating antibodies, specifically in this case IgE. They selectively bind circulating human IgE, used in addition to usual therapies in some patients who have difficult to control asthma. This specific monoclonal antibody here is usually given sub-Q every 2 to 4 weeks. It peaks in 7 to 10 days. Serum IgE levels drop about 1 after, however, the first dose. It's been shown to reduce emergency department visits, reduce steroid use, reduce rescue therapy, and the quality of life is mainly improved. Its adverse effects, ironically, are anaphylaxis, parasitic infections, but there's no proven rise in cancer rates in patients taking this specific monoclonal antibody.